Good evening. It is great to have so many of you from across the country join us for our webinar on prostate cancer early detection, treatment, and resources. This webinar is brought to you by Zero, the End of Prostate Cancer, in partnership with Florida Urology Partners, Tampa General Hospital, and Janssen Oncology. My name is Jeremy Patch, Director of Patient Programs and Education here at Zero, and I'll be serving as our webinar host. I want to thank our featured speaker, Dr. Alexander Engelman, for sharing his time and expertise with us. I will introduce Dr. Engelman in just a moment. Before we begin, I'd like to go over a few housekeeping items. Today's webinar is being recorded and will be posted on our website, zerocancer.org, tomorrow. As soon as the webinar ends, you'll see a link to a survey, and we would love for you to participate so we can get your feedback on this event. Tomorrow, you will also receive an email with a link to the recording and the survey. For those of you not already familiar with Zero, Zero is the leading national nonprofit with the mission to end prostate cancer and help all who are impacted. Zero advances research, provides support, and create solutions to achieve health equity to meet the most critical needs of our community. We offer an extensive portfolio of patient support programs and educational tools that are offered at no cost to patients and families. If you or someone you know is in need of resources at any time while facing prostate cancer, share these resources and let them know we are here to help. I'd like to spend just a moment highlighting a few of our support programs. 0360 provides individualized case management to help patients and their families connect with financial assistance programs, navigate insurance, and find other kinds of support, including emotional support and transportation assistance. Zero also offers peer-to-peer support through our mentor and caregiver connector programs. We match patients and caregivers with peers who've had similar experiences to provide ongoing one-on-one support. Zero Connect is our online private Facebook support group, and Inspire is an online patient forum. These groups allow you to connect online with others affected by prostate cancer, learn from their experiences, and ask questions from patients and loved ones across the country. Last fall, Zero and Us Too merged to become one organization, which was incredibly exciting. With that merger, the Us Too support groups became the newest addition to Zero support programming. Support groups are offered all over the country and provide a space for people to connect with others in their community. Virtual support groups are also available, as well as groups for caregivers, Black men, the LGBTQIA+ community, deaf men, and Spanish-speaking men. Most of our support groups are still meeting virtually, but some are working to get back in person, so be sure to check our website for all of the current information. Also on Zero's website, you can find a variety of educational resources, including questions to ask your doctor, patient guides, and up-to-date content on diagnosis and treatment information. There you can also find a nationwide database of sites offering free or low-cost prostate cancer screening. We also have a full calendar of upcoming educational events. On July 20th, we will host a town hall on genetics, the PROMISE study, and their roles in prostate cancer. On July 27th, we will host a webinar on prostate cancer in the LGBTQI+ community. A registration link to the July webinars will be in the follow-up email to this webinar. We continue to add webinars throughout the year, so be sure to check our website and look out for emails about these and other events. I'd like to take another brief moment to thank Florida Urology Partners, Tampa General Hospital Cancer Institute, and Janssen Oncology for their generous partnership and sponsorship of today's webinar. The Zero team is extremely grateful for all of your work for the prostate cancer community. Today's webinar will be led by Dr. Engelman, who will provide us information on prostate cancer early detection and the importance of testing. We will then take questions from our audience, so please feel free to type your questions at any time in the Q&A box located at the bottom of your screen, and we will do our best to get to as many as we can. Now it's my pleasure to introduce Dr. Alexander Engelman. He is the Medical Director of Radiation Oncology at Florida Urology Partners and a member of the Tampa General Hospital Cancer Center. Dr. Engelman received his medical degree from Georgetown University School of Medicine and completed his radiation oncology training at the University of Maryland Medical Center. Thank you, Dr. Engelman, for joining us today. We're excited to hear from you.
Thank you, Jeremy, for the introduction. I'm excited to get to go through one of my passions here, which is prostate cancer and men's health. Not in that bio, I'm an avid Lightning fan, and I got a Stanley playoff game today, so I would be remiss in not saying go Bolts, especially because one of our very valued team members in the room here is an Avalanche fan. So got to keep it spicy in the office. We're going to talk about early prevention and screening, early detection, treatment, and resources for prostate cancer, with a focus on early detection. And I would also give my thanks to Zero for this opportunity. I always like to start to put prostate cancer into perspective as the second leading cause of prostate cancer death among men, and the leading cause of non-skin cancer diagnosis of cancer in men. We just went through and still are evolving in this nationwide and global pandemic. And it's interesting to also put those cancer deaths and heart disease related deaths into the context of COVID-19. Whereas in August of 2021, about 700 people died daily of COVID-19. Unfortunately, 94 men died of prostate cancer. And this is a number that while we get COVID-19 under control and those death rates have declined, unfortunately in the recent years, prostate cancer mortality has remained relatively flat, if not unfortunately minimally increased. And we'll talk about some of the reasons why. Early detection is where we'll spend the majority of today's talk. I'm happy at the end to answer questions on any realm of prostate cancer, but I wanted to take the opportunity to really encourage men to think about their families, their friends, their loved ones, their faith communities, and encourage those people who could benefit from screening or early detection to go out and seek care for any cause, any cancer, but especially for prostate cancer. Early detection in the world of prostate cancer, of course, involves screening with digital rectal exam and PSA, and there can be a number of reasons for PSA to be elevated that are not cancerous. So it's always important to follow with urologist and get to the bottom of an elevated PSA. Such things as enlarged prostate or prostatitis or bicycle riding can do it. And there are established PSA levels that are normal for men of various age brackets, but always good to have a urologist's guidance in that regard. Screening PSA, doing a PSA on an annual or biannual basis has varied over time and varied in terms of how strongly or not it's recommended by guidelines from very well-respected health organizations across the globe. Here are featured two fairly different guidelines. The American Academy of Family Physicians does not recommend routine PSA-based screening for prostate cancer. They go on to say that men aged 55 to 69 should discuss the risks and benefits and engage in shared decision-making with their provider. But they lead with the statement that they do not recommend PSA-based screening. And I think that, and we'll talk about, that comes from a historical perspective of the way prostate cancer was screened and treated. And I think we've come a long way in terms of avoiding over-treatment and lowering the hazards associated with screening. The European Urology Association guidelines are on the left, and they recommend PSA screening, at least a discussion, an informed discussion, for any man over 50, for men over 45 of African descent or with family history, and men with a BRCA2 mutation over the age of 40. And I think this is probably closer to where I lie in terms of recommendations for screening. We know that when you catch cancer early, you can treat it at earlier stages, have a more likely successful outcome with lower toxicities, and save lives. This disparity between the two screening recommendations is not new. This has evolved over the last decade. In 2012, the U.S. Preventive Services Task Force made a recommendation against routine screening, and then in 2018 sort of walked that back to say it should be a shared decision-making between patients and their healthcare providers. And that arose from a number of studies. One is the PLCO study, where they took men and they randomized them to screening PSAs or not, and found that many men ended up getting procedures or even treatments for prostate cancers that may not have had significant clinical impact. And that's part of the balance, is that early detection and enhanced screening needs to be in concert with judicious treatment recommendations. And so based off of this older study, based using a lot of PSA crossover and older recommendations in terms of the thresholds for treatment, about 1 in 1,000 men avoided prostate cancer death of the 1,000 that were screened. And so this led to the recommendation against routine screening. But that's resulted in some changes in the last 5 or so years in terms of our diagnosis of prostate cancer. You can see the prostate cancer line here on the left graph, starting in the early 90s or so, really begins to decline. This is age-adjusted cancer death rate. So the mortality from prostate cancer really begins to decline, mostly with the advent of PSA screening, until the mid-2000s and early 2000s, in which time it plateaus. It's a little hard to see on this graph, but some more recently published data that reflects back on that time period does show us that men were less commonly diagnosed with local disease from mid-2000s onwards after that recommendation, more commonly diagnosed with cancer having spread to the lymph nodes, and more commonly diagnosed with cancer having spread to the bones. So clear evidence that screening helps men catch cancer early and avoid the spread of cancer. And in fact, that results in men dying less often of prostate cancer. These are busy graphs, but the same story: less local disease after this break here, where there's a change in recommendations for screening. When men are screened less often, more of them are diagnosed with metastatic disease. And on the bottom here, this is mortality. And I'll read you their findings. It says prostate cancer specific mortality rates flattened or increased after the recommendations, which was inconsistent with the mortality trends against all cancers, which have improved over time. So this is not to criticize the guidelines. I think we need to be judicious in our recommendations, but there are still some holdovers in terms of primary care recommendations and task force recommendations that don't as strongly encourage a discussion of screening. And if we don't screen, more men die of prostate cancer. These differences are small but substantial. We know these men and we see them in our clinic, and it's heartbreaking. And so if we can do anything to prevent a single death from prostate cancer, in my view, it should be done. And I think that involves speaking to our family members, speaking to our community about the benefits of screening. The earlier you find a prostate cancer, the earlier the stage, and the less chance that it causes some major problems. So death from prostate cancer is, of course, something that is serious and we want to avoid. But there are a lot of other potential consequences of late diagnosis of prostate cancer. On the left-hand side, we can see here men who are diagnosed early, even 10 years later, have low rates of spread to the bones, fractures, blockage of the nerves or of the urine flow, and it takes many years to develop that. Whereas men who are diagnosed at later stages have a much higher percentage chance of having those serious events and a much shorter timeline to developing them. So catching things early not only, of course, improves survival, but even more substantially avoids these significant impacts on quality of life. And it should be a shared decision making, because we've come a long way between in the last 10 years. both in terms of treatment and in terms of diagnosis, but also in terms of precision and genomics and our ability to predict who may need treatment and who can be safely observed. It's important to caveat that discussion with the notion that enhanced detection, performing screening as a more routine basis and having a lower threshold to screen really does rely on the oncology and the urology world to recommend judicious treatment. And this is the cover slide from the PROTECT trial, which randomized men to active surveillance or upfront treatment, and with no difference in long-term survival between those two approaches. So it's very, very safe to defer treatment for certain localized, well-behaved prostate cancers. And we have to keep that in mind, that many of the recommendations against screening were in an era where everyone proceeded to treatment or where there was heavy over-treatment. And so it is not incumbent upon us not to look for cancer. It's incumbent upon us not to overtreat the cancer. We should still be screening men to catch it early, and much more so in certain risk groups. Recapitulating that screening delay that we saw between 2012 and now in the last decade, less screening resulting in more prostate cancer deaths and later diagnosis, really driving home the message that catching early is the best way to treat. We had a mini recapitulation in the last few years in terms of COVID-19. We saw in 2020, the rate of many cancer screening tests declined substantially, appropriately at that time, of course, because of the uncertainties of communal spread and conservation of healthcare resources. But you can see mammography, colon screenings, lung screenings, prostate screenings, all heavily declined through mid-2020. Much of the delay in diagnosis or the delay in treatment may not, in some cases, have resulted in impacted care, and that's reassuring for people that are waiting for an appointment or are nervous about the delay in workup, or who are still processing that delay in diagnosis from 2020. It does not look that surgical outcomes, at least, were inferior when that delay extended for several months. But we do know that when we didn't screen, again, like the decade from 2012 to 2022, in the year of 2020 as compared to 2019, we saw a higher number of men with stage 4 prostate cancer. And there was a diagnostic deficit of about 10,000 men who were at the time, and some may remain undiagnosed and have the potential to experience a stage shift, meaning that they wouldn't find out about it until it's significantly later or even too late. And this, to me, speaks to the fact that we need to reinvigorate the trust in the safety of cancer services and screening, and that need to reassure patients that it is, of course, safe to come into the clinic and safe to undergo these screening tests. So our screening recommendations, both institutionally and as a result of the pandemic, have not been as robust as they otherwise could. And I would hope to suggest that that if you're judicious in terms of treatment recommendations, that screening earlier does actually result in better outcomes. So again, if you know somebody, have them get screened. These screening recommendations do vary from organization to organization. This is similar to our early recommendations, but there are certain groups of men that should get screened earlier and or differently. One is men of African or African Caribbean descent, starting at age 40. We know that men in that group do have a higher incidence of prostate cancer and do have cancer outcomes that are not the same as their matched peers for a number of reasons. This is a slide from the Prostate Cancer Foundation, which is also a good resource, and they recommend screening at age 40. Kasia Yamoa, a radiation oncologist here in the Tampa area, who's a thought leader in this regard, spearheaded this review of some of the disparities in that African American men face when being diagnosed and treated for prostate cancer that leads to the 1.8 times higher incidence of prostate cancer, 1.8 times more likely to be diagnosed, as well as the 2.2 times inferior outcomes or more mortality from prostate cancer. And genomics does play a role in incidence, but the biggest modifiable factor there is, of course, access and quality of care. Interestingly, in this column, in terms of treatment response, many studies have substantiated that men of African American or African descent have just as good, if not better, responses to radiotherapy. For example, a study from the VA this year showed men matched within the VA healthcare system that of African descent that received radiotherapy actually had better outcomes compared to their non-African peers. And so it's not necessarily a response to treatment, more so a question of screening, higher incidence, and potential barriers to access and quality of care. And so I'd encourage anyone who wants more information there to get resources from Zero and or the Prostate Cancer Foundation, because they both have very good resources. Germline variant mutations do vary between men of African American or European ancestry, as shown here. Recently, the degree of BRCA1 or BRCA2 ATM and RAD51 mutations are interesting in that there may be differences in how these groups of men respond to some of the newer treatment options. But certainly men with gene mutations do also benefit from earlier screening. And part of the difference in African American and non-African disease outcomes has to do with screening. On the left is a re-examination of that 2012 recommendation against screening and the changes in relative racial groups. So we knew in the top left here, prior to that recommendation, we saw that prostate cancer-specific survival was lower for African American men. After the recommendation changed, African American men and Caucasian men were equal in terms of their survival. And you can see on the top right that when there was a change for the non-African American population, the survival declined when there was less screening, but no change after those recommendations in the African American population. So this would suggest that prior to the recommendation, there was actually less screening, and that lack of screening persisted, suggesting why there was no change in mortality over time in this population. Like Dr. Yamoa had suggested, one of the barriers there is access, and one of the screening tools and diagnostic tools that's very useful is an MRI. And just based off of differences in geography, socioeconomic status, and residential segregation, there is a difference across about 40,000 Medicare beneficiaries in terms of how likely men are to be recommended for an MRI. So as providers and patients, we need to make sure that we recognize some of these potential inherent biases and address them. Men with known genetic mutations and alterations also do benefit from enhanced screening. This list is long in terms of men with first, second, or third degree relatives of breast, colorectal, endometrial, ovarian, pancreatic, or high-risk prostate cancer, and then or known genetic mutations. But I would encourage anyone who's interested in this topic or who has questions about their own family history to seek the resources of Zero or the National Comprehensive Cancer Network to get guidelines in terms of qualifying for genetic testing, because knowledge is power, and we highly encourage all appropriate men to get genetically tested. We know that it makes a difference because genetic mutation carriers are at higher risk for both higher grade cancers and for the development of cancers, especially men with BRCA2 mutations who have a higher incidence, a younger age of diagnosis, and have more clinically significant tumors. So men with genetic history, family history, and of African American descent should have enhanced screening starting at age 40 to 45, depending on recommendations. But that must be balanced against the notion that all prostate cancers require emergent treatment, because many of them can be safely observed for quite some time. Screening itself is not just PSA. There are many adjuncts to screening that can help refine the diagnosis and the risk stratification of a prostate cancer. MRI fusion biopsies help you, if you do need a biopsy, make sure that you get the best chance to get the worst of it, at least on sample. And then other laboratory tests can help you decide when to perform a biopsy or when to re-biopsy, or who or whom not to treat. A study presented at ASCO a few years ago looked at a number of these factors and combined them. These are both blood tests, MRI tests, PSA kinetics, but also some urine testing. And the combination of them resulted in varying rates of either avoided biopsies, which is an important endpoint, or in missed high-grade prostate cancer, which is also a very important endpoint. So discussing with your provider, if you do have an elevated PSA, what other adjuncts to testing or routes for biopsy could be considered can help avoid overtreatment and overdiagnosis. And then once diagnosed, the era of genomic stratification has really been useful, especially in the field of radiotherapy, in terms of escalating or de-escalating therapy, or recommending or recommending against active surveillance, because the classic risk factors did not have enough granularity, and 2/3 of patients even could be reclassified based off of genomics, according to this data point. So we'll keep it brief, focused on early detection. I think the take-home message is speak to your family, to your community. If people are not getting screening tests, either because of valid recommendations from healthcare groups, or because of reluctance, I think that the data are fairly clear. Early detection results in earlier stage, more likely cure, and less prostate cancer death. So go to the doctor, ask about PSA testing, and let's catch prostate cancer early.
Thank you so much, Dr. Engelman, for that information. That was great. We will go to our questions. Just a reminder that you can, for our audience, you can enter those in the Q&A box at the bottom. We do have a few questions, though, coming in, so I'm going to present those to you. So first question, for those age 70 or over, what is the first step in testing for prostate cancer? Is it still what they say, is it a blood test? Is it PSA, or is it a MRI?
The guidelines vary in terms of strength of recommendation for screening for prostate cancer in men over age 70, with many organizations recommending against prostate cancer screening. Like everything, it needs to be a shared discussion with the healthcare provider and that particular man's appetite for risk, as well as his risk factors. There are many risk factors for prostate cancer that are changeable. Diet, good exercise, anti-inflammatory, antioxidant diets, cruciferous vegetables, all of those have been shown to lower the likelihood of development of prostate cancer. So not just genetics and family history and race, but also lifestyle. So if you have a risk factor, it's an important discussion with your doctor in terms of screening. As we all age, the prostate can enlarge, and the PSA threshold for intervention does go up, and so PSA testing remains one of the standards there to avoid overuse of MRI. But in that age group, I would be even more prone to recommend the use of these adjuncts like an MRI or like a urine exosome test to try to ascertain what is the likelihood of a clinically significant cancer, avoiding overdiagnosis and biopsy as men age.
Thank you. Similar question. Is PSA screening sufficient, or should I ask my internist to do a digital rectal exam as well?
Digital rectal exam remains an important part of screening. The majority of cancers are diagnosed by PSA these days, but we have all anecdotally seen men who've been diagnosed based off of digital rectal exam who ended up having clinically significant prostate cancers. So if there's any uncertainty in the PSA, digital rectal exam should be performed. As a whole, unfortunately, in medicine, we rely so much on technology and imaging and advanced blood tests that in-depth physical examination has not been as thoroughly taught in medical school training, and is an important and declining art. So I do favor screening with digital rectal exam, although not all providers agree. That's a part of the evaluation that I think probably steers some men away from being screened. So it's worth saying you can get screened for prostate cancer without a digital rectal exam with a PSA. But if you have, especially risk factors, or if you have personal concern, a digital rectal exam is an important component of the evaluation.
Okay. Thank you. This question, does a TURP prostate surgery, and if you could please explain what that is too, but does a TURP prostate surgery, which removes only a fraction of the prostate, change the PSA?
Yes, the PSA is produced by the prostate, also to some tiny degree by other tissues as well. But when you remove a percentage of the prostate tissue, then the PSA does go down. And so we commonly see PSAs decline even substantially after a TURP procedure. A TURP is a transurethral resection of the prostate to help open up the urine stream. There are other procedures as well, like a urolift or a Rezum or a green light laser that can a little less invasively open up the urine stream, but that don't give you a tissue result. It's nice that a TURP is a nice procedure in that you get pathology from it too, so you can check to see was there cancer present in those specimens. But yes, typically we do see PSAs in the long run decline after a temporary spike following a TURP procedure.
Do you reach out to family medicine to educate them on the importance of testing? And this could be, you know, not just you, but maybe broader for the urology field.
You know, the individuals who sit on these guideline panels do often overlap in terms of their membership, and it's always an interesting discussion between those groups in terms of their preference. And yes, it needs to be a conversation, because family medicine or primary care physicians have to feel comfortable that if they do recommend screening for prostate cancer, that they are not automatically, you know, subjecting that man to treatment, necessarily to treatment or to procedures. They have to have we all have to have a shared role in managing the utilization of medical services appropriately. And I think it's important for our the front lines of our healthcare system, the primary care contingent, to know that the urologists, the oncologists, that the specialists have our national interest in mind in terms of avoiding overtreatment and overuse of procedures.
Great, thank you. So there's a lot of there's a few more on screening, but there are a lot on you know, diagnosis or once someone is diagnosed too. So but there are a few on genetic testing too. I'm going to try to get to some of those too. So first, related to that, is genetic testing done more frequently earlier in the disease state? So perhaps at the urologist's office, or is it more likely something that an oncologist might recommend?
It's useful every step along the way. And there are emerging data. I think the PROMISE study webinars will be interesting, coming up here next week. But there are emerging data that we very vastly underappreciate the frequency of those genetic mutations when we only test men who meet the historic family history criteria. As many as 40% of men may be underdiagnosed for having what could be an actionable mutation. The earlier you test, the better, because these tests are linked as FDA companion diagnostics to more advanced therapies like PARP inhibitors, but they also inform the likelihood of local recurrence, and they can inform even the sensitivity or tolerability of radiotherapy. So at every step along the way, not only is it useful information to have for family members and for personal screening, but it can impact management both from early stage as well as advanced stage prostate cancer.
Okay, thank you. I feel like there were more on genetic testing, but I'm having trouble seeing them. So maybe just let me see if I can generalize this. I'll just read it. My father and my brother, along with me, have had prostate cancer. However, genetic testing of both my brother and I show no problems. What advice might you give someone like us, or our children at least, when they themselves have had show no problems, it seems like, than genetic testing? Would it still be recommended for their children to seek genetic testing?
So I'm reassured, of course, by a negative genetic test result. The need for enhanced screening in a family with that history, I think, is still there. And so, just despite recommendations, those men and women, for that matter, should make sure that they embark on well-informed discussion with their primary care doctors about screening, and probably undergo screening tests. The nice thing about many of the genetic testing companies is that it is an evolving art, and that as new data constantly enters the system, and as they query the panel of genes or variants that may not be linked to obvious clinical significance now, as more data is accumulated, that information can change, and maybe an altered spelling of a gene that's not spelled the incorrect way or the high risk way, but not spelled the normal way, most common way either, maybe that gets reclassified in the future. And so having genetic testing done now amongst all the individuals serves the next generation in terms of informing what those alternative gene spellings can ultimately mean. With a father, with a grandfather, a father, and an uncle with prostate cancer, depending on the age and the stage, yes, that individual may even meet criteria for genetic testing when age appropriate. I certainly wouldn't cause alarm. If there's a negative test result, that's of course reassuring. But as that next generation enters the age bracket where it's appropriate to screen, I think that's an important time to consider the role of genetic testing.
Okay, thank you. And I would say a conversation probably with the genetic counselor too might be beneficial.
Agreed.
In addition to the primary care. So we've got a lot of questions, several questions that I would boil down to, for those who are diagnosed, briefly share highs and lows or pros and cons of surgery versus radiation.
Happy to. In a discussion we have many times a day in our clinic, there is no right answer across as a generalizable. It really comes down to a particular man's favorite logistics, his baseline urinary symptoms, his operative health, and his disease criteria. As a generality, of course, there is some temporary incontinence and sexual dysfunction with surgery. There is irritated and uncomfortable urination with radiotherapy, there is sexual dysfunction as well, and there are some changes in the bowels. So the side effect profile helped guide us there. A man's age plays a role, the potential need for salvage therapy. I would say that the best thing that can be done is seek as many opinions as possible. In the majority of cases, prostate cancer, thankfully, does not change day to day, and so there is in cases the luxury of time to be able to seek multiple opinions, to survey a wide range of providers and get many inputs. There's again not one right answer, so a man can't go wrong there. You really have to follow his gut. But the baseline urinary symptoms, the age, the genetic risk, and his preference are the main components that help guide that decision.
Thank you. You actually answered another question, because there was one on here related to how much time does someone have to, once diagnosed, to seek options. So you covered that as well. So thank you.
I wouldn't delay seeking advice. I would certainly get advice early. At the same time, I wouldn't feel as though the ground is moving underneath your feet. In the majority of cases, you do have time to make an informed decision.
Okay, thank you for clarifying. Do you recommend additional, again, more broadly, do you recommend additional testing after diagnosis of prostate cancer from a biopsy, such as MRI or PET scan? Anything else? Any other imaging?
Yeah, our imaging tests have evolved in recent years. We have a lot more high sensitivity and higher specificity nuclear imaging, like PSMA PET scans or Exhuman PET scans. But the standard whole body bone scans and CTs of the chest, abdomen, pelvis remain important tests. MRIs are irreplaceable in terms of their resolution and defining prostate cancer within the prostate and evaluating for spread outside. So from an imaging perspective, an MRI is usually a useful test, and then depending on risk stratification, excluding the presence or identifying the presence of distant disease is very important with either a PSMA or an Exhuman PET scan or whole body bone scan. In addition to imaging, genomic testing is incredibly useful to help guide intensity of therapy. We've got a lot of discretion as radiation oncologists or as surgeons or medical oncologists in terms of the scope of our treatments, the intensity of our treatments, and that translates into potential side effects. So striking a fine balance between not compromising in efficacy of treatment, but preserving excellent quality of life can really be informed by genomic classifications like a Prolaris or a Decipher or other tests of the biopsy pathology.
And we've got a few questions from individuals who are on active surveillance. Is there general guidance on how best to monitor their disease and keep on top of it, and monitoring their PSA levels, and at what level maybe do they need to be concerned or consider treatment?
Like anything, it is a factor of a man's other health and age. So there's not a hard cutoff to say over this line you must do something or you shouldn't do anything. The most important thing during that time is to focus on your lifestyle, on your diet, on your activity level, because those things have been shown to lower PSAs in men on active surveillance. One of the resources back in the slide deck is the NCI, the National Cancer Institute, puts out a physician data query on prostate cancer supplements. And I would encourage anybody to check it out. They've got a host of information there, but they evaluate things like green tea, lycopene, pomegranate seed, turmeric, cruciferous vegetables, soy, selenium, vitamin E, many of these over-the-counters or natural food products and the data behind them. And some of them have fairly, in my mind, fairly strong data that they at least lower PSAs. Does that translate into decreased need for treatment in the long run? Not in every case, surely. But I think the main focus on active surveillance should be on healthy lifestyle. An interesting study was published very recently on the use of enzalutamide, which had been previously used in the advanced disease setting. Xtandi is the brand name. And this trial randomized men in active surveillance to enzalutamide or plus active surveillance or active surveillance alone. And there were some side effects, but less men ended up ultimately needing treatment for prostate cancer. So it's an interesting article published very recently, I think, JAMA Oncology. The frequency of PSA monitoring used in the PROTECT trial is what I usually default to. So every 3 to 6 months with an MRI and or biopsy at the 1 year to 18-month mark. But that cadence really does depend on a man's age and other health. If it's a 55-year-old man, I think that being a little more thorough makes sense. If it's an 85-year-old man, especially with low risk disease, he may go a little further interval between very safely go further interval between checks.
Okay. Thank you. Last question that I'm going to present to you for the evening. Can you discuss the pros and cons of proton versus photon radiation therapy?
Sure. An interesting technique close to my heart. I trained at a proton center at the University of Maryland in Baltimore, but don't currently use the technique now. And proton technology as a generality is one way to change the side effect profile of our radiation treatment. Probably more meaningful impact on the safety of radiation comes from the volume of that center, how much prostate cancer they treat, their disease site experience there, as well as either an anatomy or changes in the anatomy. So we have men do some prep work before their radiation treatment, and being diligent about coming with a favorable anatomy does wonders in terms of enhancing the safety of treatment. There are rectal spacers that can be inserted behind the prostate to help protect the rectum or the nerves. There's a new one on the market called Berry Gel, just FDA approved earlier this month. That and Spacer are great products to help protect the tissues nearby. Protons versus photons are another way to try to enhance the safety, and you can find data that to support both opinions, that protons are superior or that even photons are superior. When I think of them for men with localized disease, I think of them as roughly a wash in terms of toxicity and efficacy. Again, you can find data to support both approach. Certainly in the area of retreatment or advanced nodal disease, then there can be significant advantages to enhanced techniques like proton therapy. But our rates with photon therapy of toxicity, clinically significant toxicity and disease cure are very, very good in the modern era, and more substantial impact in terms of the safety of treatment can be made with rectal spacers, with proper prep, with a dedicated disease-specific team than the difference in how you deliver a radiation.
Okay. Well, thank you so much for answering all our questions, for your presentation. It was great information. We really appreciate your time and expertise. And thank you to our sponsor and partners, Janssen Oncology, Florida Urology Partners, and Tampa General Hospital Cancer Institute. As we close our webinar, I want to remind you to please fill out our short survey and to be on the lookout for an email with the recording from today's webinar. Thank you, Dr. Engelman, once again.
Jeremy, thank you very much, and thanks to Zero for all you do for our men with prostate cancer.
Thank you. We appreciate that. I'm going to stay neutral on the Stanley Cup Finals. I have family in Denver, and I'm a St. Louis
Uh-oh.
Blues fan. So, so I will just say, may the best team win. But
We will.
we hope you enjoy. We hope you enjoy the game. Thank you, everyone, for joining us, and have a good evening.